Good evening, everyone, and thank you for joining us here for the Hunter New England Central Coast Primary Health Network's 715 education event. Thank you for dialing in tonight. Under these circumstances, we obviously can't do our roadshow that we would normally do, but appreciate your attendance tonight, and feel free to ask away questions in a way that I'll explain shortly via Slido. There'll be a slide shortly to explain that. First of all, before we get underway, I'd just like to introduce the PHN's new Aboriginal Health Manager. That's Lisa Shipley, for an acknowledgement of country. Thank you.
Thank you, Brendan. Yama, my name is Lisa Shipley. I'm a Gomeroi woman from Tamworth, northern New South Wales. I am Brenda McGrady and Bill Benger's granddaughter from Toomelah Mission Station and Boomai. I pay my love and respect to the love and guidance throughout my life that they gave me. I pay my respects and would like to acknowledge the traditional custodians of the land that we are meeting on tonight, and to those that care for country and language. I pay my respect to all elders, past and present, and to my brothers and sisters and colleagues in the room and that are joining us tonight. I also pay my respects to our children, who are our gift of tomorrow, and to those that walk beside us in our quest for equity and justice in our country. Thank you.
Thank you, Lisa. That was lovely. As you see on the screen, there's a link to Slido. Slido is the platform if you haven't dialed into one of our events before, and the evaluations are all hosted on Slido, as well as your questions can be posted on Slido. So if you go to slido.com, enter the code 715, or you can also scan the QR code on your screen now. So please fire away those questions and we'll do our best to answer them as we go through the evening. Tonight we're lucky enough to have some excellent guest speakers with us who work in this field day in, day out, and that is Tremaine Rankmore. So Tremaine's an Aboriginal Health Practitioner, and Tremaine's works for the IPN Medical Centre Group based here in Newcastle. Tremaine is a Wiradjuri man whose mother is Gomeroi and his father is Walwan. Also, we've got Dr. Joel Wenatong, who's a GP registrar from the Nelson Plaza Clinic. So Dr. Joel is a Cubby man. So we're lucky to have those guys with us tonight, and we thank them for their attendance and coming along. We've also got the PHN's Aboriginal Health Access team, who have developed this presentation along with Tremaine and Joel and some other clinicians across our region. The Aboriginal Health Access team is Anthony Doolan and Zeta Knight. They're based in our New England office. We've got Jess Griffiths and Mel Watson based in our Newcastle office. Elise and myself, Brendan Chandler, based in the Central Coast office. We've also got Tony Manton, who's joining us from the Integrated Team Care program here at the PHN. And we thank everyone for coming along tonight. And we hope you get plenty out of this evening as well. Tonight, as I mentioned, you'll hear from the clinicians and the PHN staff about practical ways that you can support Aboriginal patients within your practice and give them the best opportunities for their best health outcomes by attending their annual 715 health assessment. The Aboriginal Health Access team developed this session in conjunction with clinicians across our region and Dr. Joel and Tremaine, as mentioned, and based it on feedback that we'd received over a couple of years from clinicians right across our region. The Aboriginal Health Access team are available to provide support with you in your practice around all things Aboriginal health, and I'm more than happy to work with you around quality improvement initiatives to better support your Aboriginal community in your practice. So without further ado, I'd like to now hand over to Elise Jensen from our Central Coast office. Thanks.
Thanks, Brendan. Yama, I'd like to acknowledge the traditional custodians of the land that we're on today and all the lands that everyone's on today. I'd like to also acknowledge the elders, both past, present and future. So firstly, tonight's session will have some learning outcomes attached to it. So understanding the components of an effective health assessment for Aboriginal and Torres Strait Islander people, identifying strategies to improve health assessments in their own services, improving awareness of the importance of screening, early intervention, prevention, healthcare tools, increase awareness of cultural diversity when performing a health assessment. So what is a 715 health assessment? A 715 health assessment is a preventative health assessment, also known as a health check. It provides Aboriginal and Torres Strait Islander people with the opportunity to have their health thoroughly assessed and to identify risk factors and chronic disease to manage health of our patients during the lifespan. A 715 provides access to preventative and early intervention management strategies. 715 health assessments have been proven to increase health outcomes and access to services for our mob and have been effective in early detection tool to increase patients' health knowledge. Locally, 73% of Aboriginal and Torres Strait Islander people have at least one long-standing health condition. Data suggests that only 1 in 4 Aboriginal and Torres Strait Islander health people accessed or have attended a 715 health assessment. Data also demonstrates that low uptake for Aboriginal and Torres Strait Islander people for cancer screening. A 715 also provides preventative measures with increased screening for chronic disease. It is important for Aboriginal people to have access to 715s annually. This is to ensure the consistent measurements can be compared from year to year and appropriate referral and actions are taken and followed up. This identifies the goals for the patient and are able to manage their own chronic disease or risk factors. This also identifies goals that they've already reached in their previous health assessment. Early detection, early intervention is the key to creating a healthy community. Supporting Aboriginal and Torres Strait Islander patients with information about their health works towards closing the gap on Indigenous health outcomes and improving life expectancy. Now we have a clip from Dr. Mark Wenatong. We will be sending out the information for this clip. We can't get it to work at the moment, so we'll send that out in Slido and also when it goes up on PeopleBank. So rapport building. It's really important for when engaging with our mob that you build rapport with your patients. This ensures that both parties are comfortable and assist the clinicians to have the best outcomes for their patients. Try to offer the same clinician that you had in previous health assessments. This ensures that the patient feels comfortable and avoids repeating questions they've already answered. Have a quick yarn at the beginning of the appointment, so don't go straight into the clinical components of the health assessment. Have a chat to your patient about the health assessment and give them examples of how it would help them. So keeping them out of hospital, keeping them well, and making sure that they look after themselves and have success around the early intervention. Don't use medical jargon. An example of this is blood glucose levels. Instead, ask them if you could check their sugars. Let them know that they don't have to answer any questions if they don't feel comfortable, but you're happy to answer any questions for them. Ask them what the main thing they have come today to yarn to you about, and talk to them about what you'll be asking during the 715 health assessment. I'll now pass you over to Joel and Tremaine to talk about the 715 health templates and the components of a health assessment.
Awesome.
Thanks, Elise. We're going to mix this up a little bit differently because we can. So I'm going to just talk through the different components of the health assessment, and we're going to head over to Joel and Tremaine just to talk about the practicalities of how that will work in practice. So we'll get straight into it. So there's various templates that people can use. The one that we've looked at more recently is the new RACGP and NACHO template, and it's available in the 5 different age demographics. So you've got the infants of preschool, as you can see on the slides, the 5 to 12, 12 to 24 years, 25 to 49, and the over 50. As far as templates, guys, is there anything that you prefer over one template over another, or?
No, look, they're pretty. They're good. Yeah, they're a lot easier than the older ones. The older ones were just a generic form. Really hard to focus in on things and took a lot of time to work out, and you had to go through all the. If you've done the Department of Health ones anyway, the government official ones, I found them a bit chunky. These ones are a lot better. It's split up into age groups. It's just a guideline to remind you of what to go through and how to go about it. And it's split up with certain areas that are going to cover in those different age groups. It's from what I can read, it's more based off the demographic studies on mortality and morbidity for various conditions, mainly cardiovascular disease, diabetes, renal, lung problems, otitis media is in there as well, and then a bit on mental health, and that is spread around there through as well. And so that's the kind of the main aims of it. I find it a good guide, but there are other areas that would probably do with a bit more information, especially depending on where you're located. So if you're in the middle of Newcastle compared to in the middle of the bush at Bree or wherever, there's a few different things that will come up in it that you need to think about anyway. But it's
modifying your template to suit your needs is probably important as well.
Yeah, and it kind of allows you to do that. It's more generic kind of questions with simple answers for it. But
yeah, great.
Yeah.
But anyway,
I found the Department of Health ones, as Joel was saying, they're a bit broader. Like it didn't actually say these are the sort of things we want to look for, and I didn't really like it. Coming from an AMS and then going into mainstream GPs, I noticed that it was very, unstructured really. So by looking at the new RACGP and NACHO templates, I've seen that it's more specific. So if you guys get a chance to check it out, you'll understand what I mean by that. It actually gives you more direction. Like the Department of Health one, I remember the health check was just, especially for observations, was blood pressure, height and weight, and that was it. Where's your BSL? Where's your O2 stats? Where's your waist? Where's all that stuff?
Yeah.
And that's why I think these new templates have been released, they're a lot better. And even given the age ranges, there was such a broad range, especially between 15 and 54. Okay? It's a lot happened for me in that time. That's for exactly.
Sure.
Like things do change, and you've got obviously kids are still at school, but you're putting them in the adult sort of conversation with that as well, and then you've got older people that are not older people, but getting on in age and stuff that is not going to be related to a 15-year-old. So
different
you sort of
health
need
needs.
you sort of need to use obviously a bit of common sense and ask the right questions there. And hopefully this is going to be a better guide for that.
Yeah, great. Thanks, guys. So if you get a chance, if you haven't already seen it, the RACGP and NACHO templates, they're all available. So we're just going to move through now. We've spoken a little bit about this stuff already, but some of the components to the health assessment or health check on the templates, you can see them there on your screen, but there's a variety of things and indicators that we should be looking at when we're doing our health assessment. And I suppose a question I'll ask you guys is around is there some things particularly that are important, like on the ground level, and we're going to go through all the different components shortly, but is there something that you feel really passionate about, whether it be, the social emotional well-being, the family history, or is there something like just a quick little tip that you can give the audience around something that you found really helpful and to really help the community?
I guess for me, it's more educating our patients, I know before I'd done any sort of medical training, I didn't know what my blood pressure should be, and neither did a doctor tell me. I basically went there and your blood pressures might be 120 on 80, and they go, yeah, that's great. And there's 110 on 75, and they go, yeah, that's great. It's always changing, I didn't know what range I was looking for, and so now when I get my patients in there, I'm always trying to educate and say, look, this is why we do it, or this is the normal ranges that we should be looking at. And it empowers them to take control of their own health. You know, it doesn't just give it that, that's good type of mentality.
Yeah, and I agree. Like, I was a teacher before I became a doctor, and educating patients is definitely a key to it. And just on the blood pressure, you know, just saying to them, well, you know, if you're over 50 and your blood pressure is above 140, you know, you double your risk of having a stroke and a heart attack. It means more than, oh, your blood pressure's great, keep it up, mate, you're doing good. You know, because then they teach their kids, their own community. You know, this auntie comes back one day and, you know, says, oh, my blood pressure was a bit up. Oh, what was it, aunt? Oh, you know, 150. Oh, my doc said that if it's above that, you could have a stroke or a heart attack, you know, more risk of that. And it helps build that, I guess, that knowledge base so that people can actually take care of their own health. And it's fun doing it. I like doing it. Lots of doctors don't, but that's just my passion as well, is empowering people so that they can make those healthy decisions themselves.
Yeah, great. Thank you. So we're just going to dig a little bit deeper into some of these actual components, and if there's any questions, guys, remember to pop them through on Slido, and we'll try and answer them as we go. So the Slido, download Slido at slido.com, and the Slido code is 715, and pose your questions there. So the components that we're going to dig a little bit more into now, and we probably won't go through each individual one, but if there was, so that one of the or some of the components of the 715 are the current health and patient priorities, the medical history, I mentioned that before, regular medications, and if the patient's enrolled in the Close the Gap initiative, allergies and adverse reactions, and relevant family history. Is there any sort of tips and tricks around how to get that information out of the community, out of the patients? Sorry.
Yeah, look, it's usually there in your software, but you should update it.
Yeah.
Lots of time it's really old, so just say, oh, look, it says on the computer here that you're on metformin. Have you been taking it? You're still on it? And then they say, nah, not really, you know, whatever. And so don't assume that everything on there is correct. So it's a good guide just to make sure that all those information are up to date, especially with allergic reactions, because, you know, there's new medications, there's new things that patients try, and then they have a reaction to it, but no one updates it on the software. So actually making sure that they're the specific kind of RACGP standards that we should be having for all patients anyway. But just making sure they're up to date, that's really all that is. Yeah.
And Tremaine, family history, have you got any?
Yeah, I guess, you know, going off all of those, you know, we do want to make sure everything's up to date. You know, we do have mob that travel around a lot, and obviously see more than just one GP. So it's important, obviously, to ask them about their history, ask them about their medications, making sure that it is up to date. You know, and obviously update it in your software. But if they are new to your practice or anything like that, make sure you get their records from their old practices. You know, that's probably the easiest thing to do straight away, because, you know, they're not always going to remember what sort of medication or what dosage they're on and stuff like that. So it'll make it a lot easier on you to do that. Family history. I always talk about family history. I notice when I do my health assessments now that it's not really updated. It's pretty scarce. So in saying that, I don't just ask them, oh, you know, like, what's your family history of chronic illness, or, you know, is there any chronic disease in your family? Because most of the time they don't say anything, and they'll just say, oh, no, not really. But if you delve into it and you say, is there any diabetes? They'll go, oh yeah, aunt's got that, you know. Oh, any strokes? Oh, cousin had that, you know, when he was 20 or whatever it might have been. You know, or a heart attack, oh, Pop died of that. I've just gotten 3 things just by branching it out a little bit, you know, before it was nothing on the file. So it's important to obviously talk that out with them and obviously go into those sort of things. You know, like Joel was saying, the main things are cardiovascular, you know, diabetes, renal, respiratory cancers, those sort of things. Go into them, delve into it a little bit more, because you'll get a lot more out of it. Obviously on that slide you can see the current health and patient priorities. So always look at them and see if they're okay. Ask them if they're okay. What are their concerns? What do they want to get out of today? You know, yeah, you're here for a health check, but you know, they might want a referral to go see the physio or something like that because they hurt their back or whatever it might have been. You know, it's important to show them that you're actually interested in them. You know, it comes back to the rapport slide, gaining their trust, making sure you talk to them, find out what they want. Don't just go through the health check because they're booked in for a health check. Actually talk and find out what they want.
Yeah, great.
I guess closing the gap as well for the regular medications. That's very important.
Yeah.
Most of our mob have a lot of comorbidities, you know, and price of medication can be very exy if they've got a lot of things and they need to take a lot of stuff. So it is simple as, you know, obviously a registration form that goes through Medicare and getting them on the closing the gap scheme. But then also important for GPs, obviously, to look at the PBS
Yeah.
medications and prescribe them over.
So you just search MBS, CTG, Google it, and it'll come up with a list of all the CTG medications that are actually free. Because there's paracetamol, but it's under a brand name or something like that. So you have to really be specific when you type it into your software, and then it'll come up with the specific PBS listing for it. And if they don't have CTG on the script, just write it in. Just write CTG, and probably get in trouble. But you know, regardless if they're registered or not, I just write it in anyway. Just because I'm not going to let anyone miss out just because they haven't registered for it. You know, it's kind of silly, and I don't think anyone's going to get in trouble for it, to be honest. Yeah.
So the PHN can support, and the Aboriginal Health Access Team can support practices if there's any issues around or need a bit of extra support around registering for CTG. And I think the other thing I just took out of that was health literacy and the importance of health literacy. So having those conversations around your sugars or your heart or your kidneys and those types of things to really get that extra information out. So that's great. Well, we might just see if there's been any questions posted at this stage.
While we're waiting,
You just be quiet.
but yeah,
There are a few actually. So, a good question, and either one of you can answer this, is can you give us a rough idea about the time allocation for GPs and nurses?
So I guess from my part, you know, being an Aboriginal health practitioner, so you'd be looking at your nurse side as well. Can really 45 minutes generally. You know, I've had health checks go for like 20 minutes because they're generally a young, healthy, fit person, not much family history or anything like that. So it does go along a lot smoother. And then I've had, you know, old aunts or uncles coming in, you know, and wanting to have a good yarn to you. So it's going for an hour and 20 minutes. But I guess obviously looking at practice perspective, I guess probably 45 minutes would be pretty decent, pretty good. Especially if you haven't seen them before, because it is a lot of information to get through. And then also there's a doctor's part after that as well.
which can take just as long sometimes. I usually, the practice nurse will go through a lot of things, but I'll also go through that information as well. And usually in a bit more depth. It just gives me a bit of an area of where they've gone through, but sometimes I can spend 45 to an hour sometimes, and there's going to be patients waiting. But I find that if you spend that time with them every time they come back and visit, especially that first time, it's so much quicker. Things are sorted. They know where they're up to. It just makes life a lot easier in the long run, and you'll find you'll make up that time later on when they come back to see you the next time and the next visit. And if you're looking at a time for dollar kind of thing, it's definitely well worth the 45 minutes, instead of doing three 23s or whatever. You can you make a lot more that way as well. So
Would you suggest splitting if you thought it was going to take a lot longer, it was going to need a lot more time? Would you consider splitting it, or would you do it on the spot while you've got the patient?
I tend to do it in AMSs, in Aboriginal Medical Services. You can split it. I find it's not a problem splitting it because they always come back. But in mainstream health services, sometimes you don't see him again till 9 months later, and there's things left, left in the ether, so you don't know what to do about that. So I find just sorting it out at the start, and it just tells the patient that they're worth it. They're actually
Yeah.
somebody, you know, and that the doctor's actually spending time with me, even though, you know, and I always say, oh, look, a few other patients waiting, but yeah, you're more important than them, don't worry about it, it's all good, I'll make up the time, it's fine. And they're like, oh yeah, true, man. And so it just makes people feel a lot more comfortable that they're, you know, special in a way. And,
Yep.
and every patient is. And I try and, you know, treat every patient like they're your cousin, your grandma. You know, that respect that you wanna give to people is really important. And mob know it.
Yeah.
If they get that little inkling that you're not that interested, they're like, see you later, I'm gone.
Yep.
Yeah.
Yeah, great. Thank you.
Can you do a health assessment on a patient you haven't seen before?
Of course you can. Yeah, of course you can. Definitely. That's what it's all really about. Like they try, you know, there was a bit of an aim towards, you know, making sure that the 715 is done by a regular GP or your regular GP. But look, it's more to screen for serious health concerns that are killing our people. And if you get that opportunity, if they've come down for the knockout at Central Coast and they just see your GP saying bulk bill and like, hey, I just want to get a checkup while they're here. You know, if they haven't done one, you can usually check to see if they've got one already. And most of them know because it's been, you know, get your 715 thing everywhere, and they usually have a shirt with 715 on it anyway. It's just that as long as you get where they come from and making sure that there's a bit of follow-up. So if, you know, so I'll do it a lot at the AMS that I was at. You know, they'd come from Kempsey or wherever, and then I would just do the 715 and send it back to the GP. I'll get, what's the original GP? I'll send all these files back and with all my recommendations for follow-up and things like that as well, which is really important.
I believe the Medicare ruling states around the patient's usual GP. So, and then there's some amount of times that the patient have to have seen that GP to be their usual GP. But I'm you know, hearing you, Joel, and you know, utilising those opportunistic visits is important as well.
Yeah, and you don't have to charge a 715. You can charge whatever you like. You know, it's you know, lots of people go in for the money, but it's all about, you know, making sure people get quality health and quality follow-up, and the key is really follow-up. In a lot of practices, it was the follow-up that was missing. People were just claiming the 715, doing, you know, pretty poor effort with it, and then there was no follow-up or checking on the results or anything like that. Like I had patients that were, you know, running around with a STI for 3 years before someone worked out they had it. So have fun with that. That public health, contact tracing. So really important that, if you're going to do a 715 health check and you've never seen them before, be prepared to do the time in for the follow-up and making sure that they know of, you know, any of the test results and that sort of thing.
Yeah.
You know.
And I suppose if you, like we mentioned about the MBS ruling, if you're not, as Joel mentioned, if you're not the patient's usual GP, it's still important to go through. You can still use that template. Yeah. You could bill a different item number rather than 715 and find out who that patient's usual GP is and share that information with them, because they might have disclosed some other information to you than they have with that person, their usual GP by the rules, at that opportunistic visit. Great. Thank you. Was there other questions, Tony?
There's heaps more.
All right, we'll take one more and we'll move on.
Yeah, good. This is really important as well, as have all the questions been so far. Do you recommend sharing a final outcome with the patient after you've done a 715?
Yeah, like whatever I go through with them, I generally talk to the best of my ability what my recommendations are, and also feed that on to the doctor as well. You know, I guess there's still, like Joel was saying, there's still follow-up that we need to do. It's not just they're in for that one time and then that's it. You know, like realistically you should be doing your full bloods and all that as well. So there's going to be follow-up and there's going to be, you know, I guess disclosure is what you're talking about. Like, you know, if you found that their blood pressure's high or their sugars are high, explain what that means to them. Explain the next steps, you know. I don't want people to come in and obviously find this out and then not have any education around that sort of thing that we were talking about before, and just leave with, I don't know, BSL of 15 or something like that, and they just don't understand what it means or don't understand what I need to do next. So it is important to give them the findings that you find and explain that to them. And then generally I give the doctor do a couple more assessments as well after it. I'll let Joel go on that.
No, look, it'll come. Yeah, you've got to tell them why you're doing the tests, why you're doing the examination, and what the outcomes. You definitely just share that information with patients, especially. But I try, and sometimes there's a lot. They've done a urine ACR. There's a crap load of protein, crap load of blood, crap load of glucose in there. And you're like, and the ketones is really low. So you're like, yeah, that's awesome. I have to send you to hospital, but you talk about it with them. Say, look, there's a few things here, but look, I'm more worried about your diabetes control right now. Let's focus on that for now, and what are you worried about? Because if you're worried about one thing, so I try and do two things. What they're worried about and what I'm worried about as well. And most of the time it's the same thing in a roundabout way, and making sure they're aware of what they're, where they sit. And we'll go through it in a second anyway with the OSDI risk and the cardiovascular risk tools, where it's a good way to explain that, and that's what those risk tools are set up to do.
Yep. So again, health literacy and focusing on the important information at that time without trying to overload as well. So great, thanks. Great questions. Keep them coming. And if we don't get to all the questions, we'll aim to post the questions and responses on PeopleBank once the live stream goes on PeopleBank. So the next section we talk about, and the next component we're talking about learning and work and development within the 715, healthy eating, physical activity, home and family and mood. So probably more around the social emotional well-being. Go to you first, Joel, this time. Is there anything that stands out there that you could give a handy tip to?
Yeah, look, learning and work development is just more about school and employment, how they're going at school. I often talk about racism in schools as well, because that's a big issue for me. And for lots of Aboriginal people, if I'm sure if we got rid of racism, we'd get rid of a lot of health, chronic health conditions. And there's a lot of research that backs it up as well. And talk about their experiences as well, which can sometimes be a bit confronting, but at least it's being spoken about and people get that platform to actually tell how they're being treated and someone that they in a way can trust and sometimes do something about. So it's not unusual for me to write a letter to the school saying that these things are happening, and I've got experience in the schools, the Department of Education, so I find it a bit easier to do that sort of thing. I know your bosses. They were my friends.
If anyone needs
I
any
grew
tips,
up with them.
anyone needs any tips with engaging with the schools, give Joel a call.
But it really makes a difference to the family as well, because it's someone actually cares, and it's a holistic approach. It's not just I just went to see the doctor to get my STI check, but I couldn't talk to him about anything else. And a person is a person. They're made up of all these experiences, and it's about addressing those experiences as much as you possibly can. And it sounds like it takes a lot of time, but you say, how's school? Do you feel like you're bullied there? Do you feel like there's a bit of racism there? How do you deal with it? Here are some things that we can do about it. If it gets out of control, this is what you can do, and these are some of the things you've got, and that's it. Healthy eating. Look, it's really difficult. No one tells the truth with healthy. Yeah, I eat a home cooked meal every night. Depending on where you are, like I often talk about a lot of bush tucker and foods that are available. When I was working on the coast there, working on the coast now, you eat a lot of seafood, fish, that sort of thing. How do you cook the fish? What oils are you using? I go into a bit more specific things to that to get a bit of an idea, because I get pretty sick of the patients saying, I only eat a piece of lettuce, but I can't understand why I'm 150 kilos still, So really trying to get into, it's how much, what you eat, how much, the snacks in between, the drinks you have, Bananas, I always talk about bananas because they're pretty much just sugar sticks. There's more sugar in a banana than there is in an iced tea you get out of the fridge, and they're like, oh, what? No wonder I like bananas, yeah. And so it's more those specific things that I try and target with them as we go along. The physical activity, screen time, look, the recommendation is about an hour of screen time. Look, it's, yeah, a lot of the communities where I've worked at, there's been lots of physical activity in the community. You know, it's not so much a big issue, but when you have a kid that's, you know, heavier than you, then you probably need to look at that in more detail. But you can usually play it by ear. But I just go through the, you know, it's try and get it, you know, 20 minutes, 30 minutes of outside time where you run around, run amok as much as you possibly can. You know, 5 times a day, and that's it. Home and family, I kind of talk about some of the environmental as well as the home. You know, is home a safe place? Do you ever, there's a whole lot of the questionnaires you can do, we'll talk about a bit later, but I might as well get over and done with now. But is the home environment a safe one? Do you feel, you know, if anything happened that shouldn't have happened or anything like that, depending on how old they are? But also, you know, you're living in a housing commission house, is there holes in the wall and the roof? Is there a mould problem? Is there, you know, all these sort of things, environmental conditions that really impact on people's lives through illness. And I've written lots of letters to real estates and housing commissions saying that, you know, this is, you know, causing issues with their health, something needs to be done about it, and there's a team out there within a week or 2 weeks to do something about it. So it works, yeah, it really does work.
So that advocating.
Yeah, just advocating for the patient, exactly, and it just builds that strong relationship, yeah.
Yeah, great.
And then the mood one, look, I usually use the K10, or there's a modified K9 for Aboriginal people. It's a Kessler distress score, and it seems to work a bit better than the DAS-21 in identifying distress in Aboriginal people. And that's usually my go-to for a quick screening tool for mood and other mental health issues, yeah.
Yeah, great. Tremaine.
I guess, yeah, I mean, you touched pretty much on everything there. Thanks, man.
Yeah, you do the next slide, bro.
Yeah, learning, and like you said, it's basically school, work, employment. You know, I'm looking at, do they actually attend school? You know, do they like school? Finding out what sort of their favourite thing is to do at school. You know, it gives us a good indication of what we can talk about. You know, is there any bullying issues, like you said? Probably just repeating you there. You know, healthy eating. I think we all should know pretty much what a healthy diet is. I guess when I'm writing this though in notes and stuff, I'm not just writing a good, healthy, balanced diet. I'm actually saying, you know, their protein intake is this, their diet, their dairy intake's this, their veggies is this. It gives us a better indication of when they come back next time. And I can go, well, hey, remember when last year you told me you were drinking 5 litres of Coke a week? How you going? Like we made a goal from that. Did you achieve it, or how did you go? And they go, oh yeah, no, I cut it down to just a can a day now. You know, so you're looking at, oh, okay, there's 2.5. You just cut that in half, man. That's awesome. Great job. I'm going to praise them for that as well. You know, and tell them that they are doing a good job. Shows that you care, shows that you're listening, and you're giving them realistic goals as well. You know, I'm not going to say, oh, I know you got to cut all that sugar, you got to cut out all your KFC and Maccas and stuff like that. I guess like Joel said, you know, like there are people that are going to lie about this as well. So it is kind of a hard area as well. Physical activity, exercise, like I said, 30 minutes, 5 times a week, pretty straightforward. But I just ask them what they do, you know. If they're school-aged kids, what do they do at recess and lunch as well? You know, they might just run around and play football or play handball with their mates, or, you know, they got PE and stuff like that. So there's other activities that they do at school that we're not necessarily thinking about how many days of the week do you go to the gym, you know. You're walking, how many days are you going walking or running? And home and family, you know, always trying to find out, is their home adequate, basically? Like Joel said, is there any holes or mould, or the environmental state of the home is very important. how many people are in your house? You know, could have a family of 10 people, but a 3-bedroom home. How are we all fitting into that? You know, then you go into one person gets sick, it just spreads through the whole family. You know, so that's obviously very concerning. And then, like Joel said, you can write referrals to or letters to Department of Housing and stuff like that, and hopefully get them a bigger house, or or I don't know, obviously to help them out in that way. Mood, I generally just talk about how they're feeling and what's going on. You know, it's a bit, like I said, there are tools out there that we can use, but just basically gauging where they're at the moment for me. You know, how you feel and what's been happening, have you been down or sad lately? And if they do disclose that, yeah, they're depressed or self-harming or thoughts of suicide, you've got to address it and talk to them about it. You know, pretty sure we should all know that.
Yeah, great.
Yeah.
That's good. We might have a couple of questions again from Slido.
How would you ask about family history in a culturally safe way?
Family history with like chronic diseases.
Yeah.
Okay, I'll just
Ask it.
Yeah. There's
Your mum and dad's still alive, grandparents still alive, you know. You don't have to always say names and that sort of thing. Like, I guess cultural appropriate and cultural capacity and that sort of thing. It's just asking the question that needs to be asked. There's no special way to do things. It really isn't. It's just, imagine you're talking to a close friend or something like that. You just ask.
Without the jargon, I think it'd be
without the
important
jargon.
to-
Yeah. So exactly what Tremaine said. Is there diabetes in your family? Is there any? There's no special way, and I can never understand why people have asked me those questions all the time. But yeah, I can see why it could be a bit daunting because you especially with all the it's got to be culturally correct and culturally right and culturally safe, and then you're freaking out going, oh, so I can't say anything without being racist. No, you just ask. You'll get the knack that we're humans.
It's just the same as anyone else, I'm not going to try and go and ask a different question a different way just because they're Aboriginal or anything like that. I'm just going to ask it as if they're another human. I even see non-Indigenous people and I do the same thing. There's no real difference. I'll just make sure that I have given them time, develop that rapport, and ask it with respect. That's it. And then, like you're saying, stay away from medical jargon. Like, diabetes, they pretty much know what that is. But if they don't, if they sort of see me, you go, then I'll prick their finger because they generally know that. Or anyone on dialysis. They don't go up. They generally know dialysis is. They wouldn't know renal failure or anything like that.
Dialysis,
But they know dialysis. They go, Uncle goes up there 3 times a week, So, just respectful and straightforward, really.
Yeah, great. Thank you. One more question, Tony.
And this has come up a couple of times. How do you actually get mob to attend their health assessment checks?
Put on a barbecue.
Saying you send letters, you do the whole SMS thing.
Letters, SMS, we know that doesn't work, to be honest. And that's why a lot of it's so in the clinic that I'm working now, and the reason why I started working up at Nelson Bay Plaza, I'm just plugging it there. Thanks, George, pay me some more money. But they were doing a school program, so with the high school up there, Tomaree High School, where they have an ATSI Health Check Day where the high school students were brought up to the clinic, and we do a whole day where area health come up, do some hearing tests. There's a psychologist that comes and does some just yarns with them, and we do a full health assessment day for them and it's just for them pretty much, and the clinic's just open for all these high school kids, and then their parents build up that trust as well as their younger kids, and they often come back, especially for follow up to check out what's going on. So you've got to really, I guess, think outside the box a bit on things. Before COVID, we were actually planning on doing like an artist in residence at one of the rooms at the front there. We're having one of the local artists do some there's just a more yarning space for people and that. And so the owners and directors are pretty into making it a safe space for everyone. So things like that make a difference. You know, being part of the community rather than just in the community is the trick to it. There is a bit of a push for the under 15s mark, and that helps it. So look, I'd get in contact with the schools and the AEA, the ACLO there at Department of Education, and just so we want to do a health day. You can even get the permission notes done onto their enrolment into schools now as well as an add-on part of it as well. So it just takes a bit of playing around, and then you
building relationships and with some other external providers.
Exactly. Whether it's with the local AM, or not AMS, but given it's AMS, sometimes the patients prefer to go to the private than the AMS, but even land councils and other organisations, and just say, look, we're putting on a day just to do some health checks or whatever, but you really need to get that community support, or someone in the community that will drive it and say it's okay. So usually the AEAs are finding the schools are really good, the Aboriginal Education Assistants and whatever they're called now. They've probably changed their name 5 times since I've been in Department of Education, but same role. Same role.
I found building a relationship with them to start with. If they've got a good relationship with their doctor, they'll generally listen and come back. It isn't just a letter getting sent out, but it's also educating them and letting them know, hey, I want to get you back in. I want you to have this health assessment, and tell them what it's for. Tell them what we find out of them. Tell the benefits of it. I know that now working, when I used to work at the AMS in Tamworth, it was pretty easy because we had that relationship with all of our patients. So that was very, they were in all the time, and they could come in and they'd have their health assessments. A lot of it was done opportunistic as well. And then me moving to Newcastle and starting through the IPN network and working in mainstream general practice, there wasn't a great deal of health checks being done at these practices. Okay, so it did take a bit of time for even me being Aboriginal to develop their trust as well. I'm not just going to come in there and tell them what they need to do and that, because they don't know me. They need to obviously trust me as well. But by that, it was getting out I went out into the little schools and got to meet teachers and meet the other ACLOs and support workers and other, like Primary Health Network or Hunter Primary Care. I went out into those things and got my name out there a little bit and developed that relationship with other external parties, men's groups and stuff like that. Went into those sort of places. But then a lot of it was opportunistic to start with. They were just coming in to see the doctor for their script or whatever. And me being new, I didn't have much of a patient base there, so I could just grab them opportunistically, bring them in, have a yarn to them, and do a health check there and then. So it's kind of one of those things. But now we get a roll on, and they start to trust and know and go, oh, okay, I need to come back for that. To see how everything's going again, making sure I'm still on the right track, or we found out the few things that were wrong with us, and I was working on these goals. I want to go back and see how I'm doing. So it is a bit of a journey in that sense. You're not just gonna, we're not just gonna give them a call and they're gonna come in. Even for me and Joel, like it's sometimes we just got to be aware that they've got other priorities in mind. Sometimes it could be old auntie or uncle looking after their grandkids or something like that, and football come up, so they're going to go to football over getting their health check done.
Yeah.
And that's the sort of thing where I found that they didn't notice or didn't know what the benefits were of having a health check. So it was important for me to educate them in that sense, and talk them through what we found and what we're going to be aiming for and the goals that we want to achieve now.
Yeah, great. Thanks, guys. I think a couple of plugs there for your workplaces. That was nice. I like that. That was good. That was great. So if anyone needs any extra support around some tips and tricks, I suppose, with how to engage with your local community, feel free to give the Aboriginal Health Access team at the PHN here a call, and the guys can give you a bit of a hand with some tips and tricks with that. So we'll move along. So the other next components that we're going to be talking about, and some of them we may have touched on a little bit, but cognitive memory and thinking, eye health, ear health and hearing, oral and dental, skin and immunisation. So we might just pick a couple of those things just to focus on. Start with Tremaine.
Okay. I suppose, cognitive memory, pretty much MMSE, general things that we do. It's pretty, I think most practitioners and that should know what that is. It's pretty standard and easy to do. So obviously 55 and above, I generally do that for them.
And having that baseline, I remember when you were helping develop this, you were talking about having that consistency and baseline. I think that'd be pretty important then, wouldn't it?
Yeah, I suppose, like when I do a health check, I always explain to them that I want this as a baseline. Like if you score 20, you score 20. Like you've never done it before or anything like that. I just want to know where you're at or where their height or weight is or whatever. Same with cognitive memory, you want to develop that baseline as early as possible. So if it is 55, yeah, I generally have a joke with them because I've met them the year before. I say, "You're old now, Lunk, I've got to do this thing on you." We have a bit of a laugh and that about it. And have a good yak about the MMSE, and I go, "Nah, you scored 30 out of 30, you're sweet. Come back next year, it might be a different story." But eye health, generally I always talk about, we do Snellen, isn't it?
Yeah.
Snellen, the Snellen chart, yeah. So I generally do a Snellen chart or a VA with them, and just talk about their eyes. Have they noticed any deterioration? Noticed any double vision? Sore eyes, itchy eyes, anything like that, and just note it down. Same thing there. I always explain that this is only going to tell me what you can see from here to there, but you need to go and see an optometrist, so they can look inside your eye, making sure there's no, early macular degeneration or diabetes retinopathy or anything like that coming about in your eyes, and explain the importance of having that check. At least every probably 2 years, just get it checked up. If you're a diabetic, it goes to 1 year, and they do those tests. Ear health and hearing, generally talk to them just how they're going. Have they noticed any differences? There's a new tool out called the Plum and Hats. And it's early, so I can't even remember what it's called or what the acronym stands for, but it's generally questionnaires about how they're listening and how they're hearing and how they're talking. So I generally do that for the younger kids, try and pick up anything that we can refer to a speech pathologist or the audiology. But also explain there as well that it's all about baseline. So let's go and get a hearing test done. Make sure that you are hearing 100%, or your left ear is a little bit weaker. At least you know. And then when you start feeling the deterioration, you know that, I lost 5%, not 25%, because I thought it was 100. So it's kind of how I explain it to them. Oral and dental. General gist of that one is just talk about, do they have any dental concerns? Have they noticed any holes or any sensitivity or any pain, any bleeding gums, those sort of things? How often do they brush their teeth? So a lot of this is very broad. Obviously, you want to talk different age groups as well, because then you got older people that you got dentures and stuff like that, or even kids that are just starting to brush their teeth. You've got to explain that sort of stuff. And always just dental if you can. It's always good to get a checkup. They got the $1,000 government scheme for under 18-year-olds, which is great. Get them kids checked up and that. Skin, generally asking if they've noticed anything going on or anything different. Have they developed any sores or rashes or bumps or lumps or anything like that they've noticed? but generally give that to the doctor, use a dermatoscope and look at the stuff.
That's pretty funky. Yeah.
Doesn't look all right,
That's a bad rash. That's going to hurt.
Yeah. Immunisations, I guess, making sure that they're up to date. And that's generally Blue Book for younger kids, ACER or AIR, whatever it is. Making sure it's uploaded, talking about if they've had the immunisations. And you've always got to remember that there are different age brackets for Aboriginal and Torres Strait Islander people and non-Indigenous people. So, if I get a 55-year-old or a 60-year-old Aboriginal auntie or uncle come in, ask them about their pneumonia needle because it's from 50 onwards, not 65 onwards. So you got to just sort of remember those sort of things and obviously get them immunised as best you can.
Yeah, so I guess definitely with kids, eye and ear checks, like the actual hearing test and the eye checks and everyone bulk bills, the optometrist for Koori kids, you might need to do the letter just to say that they've been assessed and referral to be put on that program. But that's definitely always do that, because especially that 0 to 7 with language acquisition and that age group, and I did work on a hearing program for 10 years, so I probably should do what I've been doing for who knows how long in schools. And so, and interesting, I was working on the otitis media program when I was a teacher in Newcastle for about 10 years and looked at about 800 sets of ears a year and worked out all sorts of different strategies. And so there's lots of eustachian tube manoeuvres that you can do. That you can just teach them straight away. So blowing up balloons, blowing their nose 3 times a day just to help clear that fluid, especially if you see that behind the eardrum, the tympanic membrane, you can see a bit of fluid behind there. Getting to do that eustachian tube manoeuvres really makes a difference. And it's all only my experience, my anecdotal data. I haven't really done a research on it. Well, did I have time to do it? Looking at that many years a year, but but it definitely makes a difference as well. Then the skin, just looking for more strep throat, just because there seems to be a bit of a connection to kidney disease in future ages. So just keeping an eye on those that are more at risk. Not sure exactly how risk is, but. How are we running for time? We smashing it? No,
yeah,
we're so late. I know.
We're going good. We've got a couple more questions coming up from Tony here from Slido. Don't forget slido.com and 715 is the code. And that's where while Tony's looking up the questions, that's where our evaluation after tonight will be.
Curly questions for Joel.
Oh, but look, skin infections like impetigo, that sort of thing. Like you've got access to the Bactroban or mupirocin on CTG, so you can get it for free. It is the nasal one, but yeah, they often don't have run out of the nasal one. They give you the cream, the skin cream anyway. It's supposed to be for staph eradication, and you can swab it if you like, and it'll be staph usually, staph or strep. Yeah. Give me a curly.
Yeah, no curly ones. Only because I know how you would answer them. Can you please explain the concept of shame and how this might impact a health assessment?
So, where does shame come from? I guess it's self-doubt in our own abilities, which comes back to the racism that's been put on our people ever since, BC or AC after Cook came down, and that sense that we're not, I guess, we don't have the skills or the skill set to be equal to other people, and so I guess the tall poppy syndrome is a way of doing it, and lateral violence is another term that gets thrown around, which kind of means a bit similar. I love it when they say, you laterally violated me, and I'm like, oh, as long as it's not horizontally violating us, okay. Sorry, I'm bad, yeah, I know. But it comes from that lack of confidence and that racism that's come. That's my theory from all the work that I've done with kids and young people, in a range of different areas, and so it's when it's being embarrassed to have a go. That's what it is, yeah, and or have a say or speak up, and it's that shame, I'm not doing that, that shame, and they say shame, and it's just like, nah, and we're trying to get kids to get out of that mindset, and so I do lots of music workshops in lots of communities for the last 20 years or so, where we teach kids how to rap pretty much. We record them, write a song, then they get up 3 days later in front of the whole school and do the song in front of the whole school. And these kids the most embarrassed kids that can't even read, and they're up on stage just freaking rocking the mic and the stage, and it's amazing to see that. And when you get the feedback from their teachers later on saying, that ever since that time, his confidence has boosted up. His marks have improved in his maths, his English, everything's just improved. And it's just that self-esteem and building up that confidence within themselves. I can't do that as a doctor. Don't have time to do fun stuff like that, and Medicare won't pay me to just go around rapping. But one day I'll work it out. But that's what shame is, and then trying to address it is probably the most important thing, and building confidence wherever you can, and like Tremaine said, giving them that good news when you've cut your coke addiction in half. That's mad, good stuff, like just building them up every chance you get is really important.
And anything to add to that?
Yeah, I guess it's just embarrassment. I find, like I'm not going to do that. That's shameful for me, but I think to put it, it's about feeling embarrassed or feeling judged if I do that. It's, I don't want to put myself out there. Like, for instance, this can be seen as shame. I'm not going to do that. I'm not going to sit in front of all these people or,
Around 300 people.
No, you just made it worse now. No. But see, that's what I mean. Like, it's just I feel, you can feel a lot, I don't want to make a fool out of myself, basically.
Yeah.
But it's something that, we build up, we build that confidence, we build our own self-esteem, and we can get over it. So I guess with your patients, it's about, just educating them and talking to them about it, and letting them know that no matter what you say to me, I'm not going to judge you. I'm not going to. Easiest thing I can say is I'll talk about alcohol with them or anything like that, and I'll generally go, so do you have a drink, or do you drink any alcohol at all, uncle or aunt or brother or sister, whatever it might be? Oh yeah, I have a little bit. I go, oh, what a little bit, like one drink or a carton? I have a joke with them, and they go, oh no, not a carton, I'm not that bad, and then they'll go, oh no, I'll have probably 5 or 6,
Half.
Yeah, half of that. Half a carton. I'll have a carton with my brother here, but that's about it. So it's probably, if you can put that platform out there to say, pretty much you've heard it all. I've heard of people drinking a carton a day. And if I say that to them, they go, oh, that's not that bad. I only drink 6, or I only drink 12, or I smoke 40 or 50 a day. I've heard of people smoke 100 a day. It's trying to make them feel as comfortable as possible, and it'll take away that shame factor.
Yeah.
Good question.
Yeah, there's another good question, and both of you could answer it. I'll start with you, Joel. So what are the main reasons you would do an EPC referral to an Aboriginal health practitioner?
For the number one is community, being having that community access to a health worker. And look, I don't know how you work, Tremaine, but in the AMSs and the other health workers that I've worked with, they're in the community lots of the time, and so they kind of bridge that. They get to go home, and look, I do home visits all the time as well. I'm not scared to do that. Most of the time it's just on my way home, so hey, I drop past, there you going, bro, that sort of thing. So it's that community access, but also just having, if you're not Aboriginal, you feel uncomfortable with some of the things talking about, that's the referral right there, and they'll sort it out. You wait to see how many I'm referring to you, bro. you come up to Bay, eh?
Yeah, I will. Can I please? No. Yeah, I guess, you know, like it's more them feel comfortable, and obviously it gives us a good follow-up for whatever they need, you know. It is a practice for like holistic care. You know, we can help them with other sort of things. You know, you can help them do their housing or social side of things, talk to them about social emotional well-being, be a counsellor. I've got referrals just because, you know, I am an Aboriginal man who's, I don't know, I can't talk myself up and say successful, but by having a job and showing these patients that my you know, you can do anything. I started out as a transport officer, you know. It's not just, you know, bang, I'm this Aboriginal health practitioner, so I think I'm all that. It's you build yourself up, and it's just about showing our younger people, or it could be older people as well, that we can do anything. That it's not, you know, there's no limit to what we can do. It's bring them in, refer them to an Aboriginal health practitioner. We can talk through a lot more stuff. I do gather a lot more information. You know, I've had patients disclose a lot of things to me that my doctors didn't know. I had one doctor tell me on my very first visit with an auntie, I got all this information out of her. He said, I've been seeing that one for 10 years and she never told me anything like that. So those sort of things, we can gather a bit more information. We can make them feel a bit more culturally safe. Yes, there is the ability to do home visits as well. Yeah, but follow up on their care. Yeah, it's a sort of a jack of all trade type thing, you know. Like I don't specialise in one thing, but I know a lot about everything type thing. That makes sense. Yeah. Yeah, and then any like follow up or education type stuff that we can do. I've been up to the hospital and done like advocating work for them, or sat in with a specialist and explained, you know, what the specialist actually said to them. There's a lot of things you can get an Aboriginal health practitioner to do, or a worker in that sense.
Yeah, and I think there's plenty of space and opportunity for Aboriginal health practitioners, Aboriginal health workers in mainstream, as I'm sure you'd advocate for, working in mainstream now. And you know, there's some great work that occurs already in AMS sector. And there's a few Aboriginal health practitioners and Aboriginal health workers spread across mainstream. But you know, I think, you know, if practices are looking to engage with some Aboriginal health workers or practitioners, again, a bit of my turn to do a plug, but just sing out to your Aboriginal Health Access team. We can help you with that as well. All right, we might move on. Again, a couple of these things we've already touched on, so we might just knuckle in on a couple of them that really stand out to you guys. Substance use, including tobacco, gambling, sexual health, social emotional wellbeing. I think we covered a bit of that earlier. So, Tremaine.
Oh, I guess that, you know, like generally I find they're pretty open and will disclose that they smoke pot or use anything really. So it's just a matter of, you know, getting comfortable with yourself in asking that
pot
question.
Pot is marijuana, just in case you don't know.
Okay.
And yandi, we call it yandi or
whatever.
ganja. Yeah.
You're going to get all these other different words for it and stuff. But it's just as long as you know, you're not. It's just that if you show them that you're non-judgmental, they will talk and they will tell you things, and they'll say, you know, oh yeah, I shot up today actually. Like, okay, fair enough. As long as you're honest, like, are you using clean needles? Are you using this? Make sure that they've got the right tools if they are going to use it to be safe themselves. You know. And I just talk about it and let them know that, hey, I'm non-judgmental. I'm not going to say, oh shit, you know, I'm going to put the cops on you, or anything like that. It says including tobacco as well, so I always talk about their tobacco, and you know, you can go into like soft drinks and sugar addictions and stuff like that. You know, it's not just necessarily illegal drugs or illicit drugs.
Bananas.
Yeah.
I learned that tonight.
Well, you know, and the facts are that, you know, alcohol and smoking are the biggest killers for anyone, for everyone with drugs. And I tell people that, I said it's the legal drugs, and then after that it's the prescription drugs that kill people. So we're probably the worst drug dealers out there, to be honest. And telling patients that, they're like, oh yeah, don't feel so judged when you give those stats, and especially when they're asking for their endone, get my down, and their diaz, and that's all patients. It's not. It's actually more non-Indigenous patients that I have those issues with. The sexual health. Look, a lot of GPs out there will be struggling with the gender and sex, men's business and women's business. Look, I just ask if they feel comfortable talking to you about it. You'll be surprised, especially if you're a female doctor and asking a male guy. I said, oh, you don't mind if I talk about some sexual health questions or anything like that? And if they mind, they'll say, yeah, I don't want to talk about that now. And if they don't, say, yeah, that's fine. And then you go for it. It's just asking that permission that it's okay, because not every Aboriginal person gets offended by those sort of things or not offended by those sort of things. So as long as you ask the question, which is what you do for mainstream anyway, so.
Yep. Yeah, great.
And then the social emotional wellbeing, we've pretty much already went through.
Covered that, yeah.
Gambling can be a tough issue to talk about, but, it's more the outcomes of gambling and the outcomes of substance abuse we try and know is it, like Tremaine said, is it a safe environment? Is there enough, money for food in the home? Or, where's some of that money going, I spend, $200 down the TAB every weekend. You're like, oh, yeah, have you thought of it? Maybe, probably spend a bit too much if you're running out of money and that sort of thing. And just I find doing it that way is useful. Anyway.
Yeah, great. All right, we might just skip straight through to the next components as well, just mindful of time. So we're looking now more at the screening and the opportunities there for cancer screening programs, cardiovascular, which we mentioned earlier, and other investigations. And I think this is the beauty of this health assessment, that enables patients annually to have this stuff followed through. Joel, we'll start with you this time.
Yeah, he's ready to go. No. So examinations, head to toe. You've got to go from head to toe, from looking for munyas or nits in the hair down to tinea between the toes. Like if you don't do a good examination, you're gonna miss things. Eyes, checking the ears. Make sure you check the ears. And if you feel uncomfortable, you don't know what you're looking at, Google it, YouTube it. It's all on YouTube there. But look,
and there's plenty of great resources on both the Health Pathways pages as well.
Exactly, and always look at the other side. You can always, if one side's different from the other side, you think, yeah, something's up. I'm not sure which side, but anyway, at least you can record it in there. I always listen to hearts, especially for murmurs. I really try and track murmurs down, especially with rheumatic heart disease and those sort of things, because you do get a lot of community people that grew up in Central Australia or even Queensland that have massive heart murmurs from failing valves and heart failure just because of that. And so having a listen so that when something does go bad, you say, oh yeah, I know you've got that murmur. And then I'd grade the murmurs as well, so always write in the notes what grade they're at. Listening to the lungs, having a look in the mouth, looking at the dental hygiene, to the throat, all the way the abdominal examination, and then muscular if there's any issues with joints, and then and any skin rashes as well. So I tend to go from head to toe really, go and sort that out, because it's really important. Really important. It often gets missed a lot, I find. But yeah, you can, like I've found kids with 14, 15-year-old kids that have been surfing and swimming their whole life and diving for whatever, oysters and things, that have ear canals the size of a pin, with really severe exostoses, and things like that where, you know, something needs to be done about it, but you wouldn't have known if you didn't check, you just wouldn't have known, anyway.
The cancer screening, I suppose it's age appropriate as well, with the age appropriate cancer screening programs. And then again, family history, I suppose.
Yeah, look, it's tough to get people to do this cancer screening into that. Like PSA is easy, you throw it on the bloods, but breast cancer, getting the mammograms, like I'm not a female, but the idea of putting my breast in a clamp sucks. But anyway, and then bowel cancer is probably another big issue, and getting patients to do that can be pretty tough, and I think it's got to be an earlier age for the screening for bowel cancer as well. So just talk about it, bring it up, saying, you notice any dark poos, blood in your poos, any of the symptoms, I said, oh, yeah, I didn't want to say anything, but yeah. I said, oh, well, look, we'll just do this check, see what comes out of it. May have to get a scope, but at least we, have a potential to prevent a bowel cancer and having a colostomy bag and that sort of thing. So it's more just using actual symptoms and making it real for them, rather than, or if you do notice you've got blood there, or your poos change, or they go dark or anything like that, it's, if we can get onto it earlier, it's going to mean a lot less problems for you later on down the track, and at least they know what to look for, and it's that educating people rather than just relying on the screening test itself.
Yeah, and then I suppose the full blood counts and the various blood tests. Tremaine was talking earlier about that baseline stuff. Again, those annual blood tests and things as well would be important.
Yeah, definitely. I mean, it's important obviously to get those bloods all done. I think it's probably the easiest thing to do, if they actually do it. But I know not most, but a lot of GP practices now are near pathologies, or actually have them attached or in their own building. Like, if you've got access to it like that, then these should be done all the time.
Yeah.
Every year at least, have it done.
To get them done as they're handing their referral.
I'd say, I would just do the HbA1c, don't worry about the fasting glucose. You can get it random in there, that gives you a bit of information as well, and the random lipids. And I said, just go do it now. And then at least if it is abnormal, say, oh look, this was abnormal, your lipids were up, your cholesterol was up. And I'll explain what all the tests are as well when they come back. I go through every test to make sure I don't miss anything, number one, because sometimes you tick the wrong box when you're going through it, and explain what the tests are and what they're actually looking for, and explain a little bit about it so they understand this is why we're doing it, not so much, oh, the doctor did some tests, he said it was all right, that's fine, but when you can explain exactly what it is. And like the Aussie risk school we were talking about earlier in our run through was, it gives you the chance to show what those results mean and how it can impact their life in the future, and give them a bit more reason of why we do it, rather than just to take your blood for no reason.
With the Aussie risk, I always do that, and then we get, like I said, the baseline of it. You might be 1 in 3 will develop diabetes. And from that, I go, look, it says, if you lower your waist a little bit, or you started exercising, or you stopped smoking, and take it away, I actually play with it in front of them as well. And I can show, look, just by you exercising more, you're now 1 in 7. Now you've quit smoking and you've started eating healthier as well, now you're 1 in 14. And you just show them that with these little changes, it will make a big, big difference. So it is important to do those sort of things. Examinations, or your basic observations as well, which I've already covered earlier. It's just important to do them all. Cancer screenings, obviously, if they have family history of stuff as well, then probably screen a little bit earlier. But like Joel said, it could just be a matter of talking to them and finding those symptoms out. Even talking to, make sure they touch their boobs really in the shower, or examine yourself while you're in the shower. Like, that's the easiest thing to do, to find any abnormalities or lumps or anything like that, so you can sort of tell your doctor. And I sort of explain that to them, and just say it's probably one of the easiest things that we can do. We're always going to have a shower and have a scrub and stuff like that, so just have a feel around, making sure everything feels normal. If you notice anything different, then come back and tell us. And there is no shame in that. It's about catching it early so we can prevent it from developing further to, so we don't lose anything, really.
Yeah, great. Thank you. The finalising the health check, I suppose, offering the patient the copy, the advice and recommendations, and then looking at any ongoing referrals, having those questions. Some of this stuff we spoke about around the questions, but I think that the referrals, the possible referrals and potential referrals, and the reason why for those referrals, I'd be interested to hear a little bit more about from your perspective, Joel and Tremaine. Yeah.
I guess, like once you finalise your health check, you're going to offer them a copy. Most of them will say no, but you still offer it. Advice and recommendations, spoke about that earlier, whatever you find, make sure you tell them, making sure you tell them the next steps and stuff like that. Do they have any questions? I always ask them, do they have any questions for me? And they might just start asking me about my family or something like that, or they might go, oh, you remember about your blood pressure? What did you say that range was, or something like that? So they'll talk to me about that. And always explain the allied health visits. So there is 5 of these attached to the Aboriginal health assessment, and I go through it with them and tell them who they can go and see, and I explain how much it reduces the cost or how much Medicare will cover, and I let them know that we do have some relationships with people in these boxes, and that some of them bulk bill, so it means you won't be out of pocket, but others, it covers just under $55, so you might be out of pocket. I don't know, if it's an $80 consult, obviously you'll get $55 back or something like that. Okay, I always explain it to them, and they go away feeling, oh yeah, I got something extra out of this as well. I got all these recommendations and things I need to work on, or little goals that I can try and achieve. But I can also go and see the chiro about my back that's been killing, or physio because I twisted my ankle at football, or whatever it might be. They got that extra stuff for them. Ensure the patient understands the next steps. GP to us, so obviously then the GP is obviously going to sign off on it and stuff, and do a couple more assessments like Joel's been speaking about, and make his own recommendations and advice to them.
I just listen to you, so agree. And look, those 5 allied health visits are on top of the EPC ones. So if you do a GP management plan and EPC, you get another 5 on that, so you get 10 all up, which can be really useful. Especially podiatry is probably the favourite, I find. Podiatry and physio, but there's a lot, there's a lot of other areas, especially for kids, speech path to OT, whatever, there's lots of opportunities there. But like I said before, there's usually a referral for the optometrist and a referral to a hearing, Australian hearing or whatever, just so at least I get those results back as well, which is important for me, to make sure they've done it, and then I've got an idea of what's going on with the hearing or the sight, and then anything else on top of that needs. And it's knowing the community as well. So I only refer to bulk billing people just to make the affordability, and most specialists will have a specific bulk billing thing for people of low income or Aboriginal people as well. As you've just got to ring them up and ask them. And we're lucky we've got a few specialists that will bulk bill lots of patients, and then I'll just refer them onto them, and they get
So having that rapport and that relationship with the colleagues as well. Yeah,
important.
Great. Okay, so talking about the nurse follow-up item and the associated telehealth item numbers with that, Tremaine. So are you doing telehealth in your practice? How's that all going?
Yeah, we are doing telehealth. Kind of find it kinking my neck, but that's a different story. But hey, it is good. It still offers our patients or anybody the ability to access GPs or nurses and stuff like that without actually putting themselves in harm's way at the moment with what's going on. And I guess, some of the ideas for the nurse follow-up. So once you complete your Aboriginal health assessment, you get access to these 10987 incentive items. Okay, I think they're about $24 or something like that, almost $25. So generally, coming back for any education they need, or they might be getting their immunisations or something like that. They've had their 715. You guys as GPs, obviously you're going to look at that, look at the patient and make sure they're okay and give the nurse the okay to go, all right, jab that person or whatever it might be. Attach it on there. It is incentive money for you guys, and for our patients, it gives them that extra level of care as well, by educating them when they come back, or, oh, your blood pressure's a bit high in the health check, let's check it again, or, there's healthy weight initiatives that they can come back. There's a program for it, but they can come back all the time and get their weight checked and stuff like that. It doesn't necessarily have to be a time with the doctor, but do it with the nurse, and then the doctor just obviously pops their head in and says hello and can add it to his or her provider number. And just making sure that they're doing okay. It could just be a check-up, check-in, seeing how they're going. It could be, we sent away a referral. How's that going? Have you actually made contact or anything like that? Nah, all right, let's call them up and see where it's at. Those sort of things. It all comes from the health check. That these are things we're going to follow up on anyways. Yeah. So we're best to add these numbers, especially for practices that need to make that extra bit of income as well. It's there. 10 times a year you get that. So
I've heard of some practices that book these in for patients just to encourage that follow-up and encourage them with that follow-up of those appointments as well. Is that something that you guys do? Or?
Our nurses will do that as well.
Yeah.
And even for the GPMPs and just that follow-up contact, you should probably come in for your review soon, go through all the issues that they have, and then they book them in straight away. So that's been really, really useful. And if they do keep, and they will probably keep some sort of form of telehealth, I think that's probably where they're going to probably pump it into, to be honest, because it works so well with that follow-up and that continuity of care, and making sure that we keep an eye on patients and not be out of pocket in a way as well.
Yeah, no, great. We might get a couple more questions, Tony, if we can.
This is a good one, and I'm sure I know the answer to this before I ask it. Is there any value in doing a 715 assessment in a baby or toddler?
Yes. So I guess from birth, obviously, you're going to do a massive 6-week check. You gather on all that information as well. So I generally let the nurses and the doctors obviously do their 6-week check because they've got to immunise and do all the other stuff. But there's no reason why you can't go through everything with them that a health check will contain. You're doing their length, weight, head circumference, gathering all their family history and stuff like that in there as well. The more stuff you can put in there, the earlier you can put in there, the better outcomes we're going to have. And then generally from 1 onwards, I'll take over that and do the health assessments from a 1-year-old. And then we're talking about their development and making sure that everything's going okay. Doing these early screenings for language and hearing and speech and stuff like that. The more, like I said, the earlier we get to it, the more information we have to obviously give them a better outcome or give them a better quality of life. They might be healthy as anything until they're 25, but you've been there and preventing anything from jumping up, or you're going to pick up something early. I've had a young person come in and I done a health assessment on them last year, and everything was fine. Everything was good, all observations were fine. Come the next year, BSL was a bit high, and they actually developed diabetes just within that year, and they're a young kid. Healthy otherwise, But if I wasn't to do that, and I noticed that a lot of my mainstream practices weren't doing BGLs randomly like I do, we might never have picked up on that until he was pretty crook, you know. So it is important to get that done as early as possible.
Yeah, definitely. Babies and toddlers, go for it. Go for it. There's so much info you can put in there, family history, get all that sorted out, and it's worth more than the 36 or the 23 you get. It's worth it in the long run. It sure is. It definitely sure is. Just taking that extra time with the family and to update all that information. You know, what was the birth like? You know, did they have any respiratory distress? Is there anything else? Like, it's just so much you can do. It's not, it's not going to be as in depth, but it is what it is, and you know, the Department of Health are encouraging it more than anything. So do it. Yeah.
Yeah, great. One more question.
What examinations would you suggest a practice nurse would do, if any?
I do all the basic observations. So your blood pressure, your height, weight, waist, BGL, you got your O2 saturation, you've got Snellen chart. You know, I try and gather as much information as I can. Examinations wise, maybe obviously check their ears. You know, you can have a look in their mouth and just report it back to the doctor. It'll make the doctor's job a little bit easier by you doing as much as you can. Especially sometimes practices will allow, you know, 45 minutes or an hour with the nurse and then one appointment with the doctor. So it's kind of really important, obviously you're working together as a team, that if you are capable of doing it, that you do it, you know. I know nurses out there that are really good with skin checks and stuff like that, so there's no reason why they shouldn't do it if they can. You know, it doesn't need to necessarily be pushed onto the doctor to do whatever they need to do. There's, you know, nurses out there that have done their ear health and all that type of stuff, so they might be able to assist the doctor and go, hey, this is what I found, this is what's going on. You know, can you just have a double check of that and put that referral through or whatever it might be. You know, so it is important to do as much as you can, and then it'll free up the doctor, obviously, to just read over your recommendations and stuff like that, and go, okay, yep, I can see T done this, this, and this. Let me just check, make sure it's okay. He was a bit worried about your ears, or he was a bit worried about, you know, I don't know, sugars or whatever it might be. So if you're stick to your scope, I guess is the...
Yeah, stick to your scope, that's it. And if something flags up, let us know, because that definitely does make it. Like I had one patient had this weird lesion on her breast, and then, you know, the nurse saw it and went, oh, that's a bit sus, you better show the doctor that one. And ended up being Paget's, but anyway. So that's pretty nasty, but you know, you do stick to your scope. But if you notice something that I wouldn't normally see, or you know, your colleague wouldn't normally see, just flag it, definitely. But I try and do all my own examinations anyway, just to make sure, because then I've got a kind of picture in my head when I see him next time. I said, oh, let's try that ear, it looked a bit manky, or it looked a bit of fluid in there or whatever, and I've always got some sort of visual picture of it. But but the doctors should be doing a lot of the examination, just because it's what we're trained to do.
Yep.
Well, at one stage anyway. Sometimes.
And then the nurses are working within their scope and competence and confidence. Yeah. There's one more question Tony's got here.
I think this is a good one. When doing follow-ups, do you try to encourage self-empowerment by having the clients book their own appointments, or would you take control in this situation?
Self-empowerment. You know, if they do require a bit of help, then I will help them. You know, I had some very high demanding patients before, you know, that wouldn't do anything without you ringing them up or ringing the specialist or doing anything for you, and trust me, it gets very tiring. So the more you can educate and put that confidence in them, or self-empowering them, that they're going to actually take control of their own health. I guess it comes to a point there where, I've had a couple of patients that, had uncontrolled diabetes, and for whatever reason, GPs couldn't get it down or get it under control. Now it took me a fair while to work, not to work it out, but to be an educator for them. It was mainly insulin injections, and I had one old aunt, I'll still remember this. She was on probably 30 units of insulin, and we couldn't figure out why her HbA1c wasn't going down. And, what happened was she would inject, she'd dial it up, stab herself, and count to 30. Now we know we need to push it in to get the insulin. So it took me a home visit to find out what was going on. And then I actually brought her into the practice every day and educated her and made sure she'd done it right, and then empowered her by not telling her what to do, but being in there with her and just being as a support. So she got that education, and now her HbA1c is, back down to 7 or something like that. And there's been a couple of those cases, so you're best to empower them. You can't be, like I said, you wouldn't be able to go there every day and inject for them, or make those phone calls to the specialist every time, or,
It's a stepwise approach, yeah. So initially you might have to do that, but then you slowly get them to, and you play it by ear. There's some patients are like, straight onto it. Others like us, look, I'm going to book you in next week just for the follow-up and the results, and then we'll go, is this day, this time all right? And then often we'll book them in straight away that way, and as we build that relationship, I get them to start booking in themselves and that sort of thing. So it's not difficult, but at these times it is a bit difficult because it's hard to. All the phone lines are being used at our medical centre because of telehealth. So the old 6 Telstra lines aren't
getting tested. Definitely getting tested.
Yeah.
Very good questions there. So, so before we move on to our next speaker, the last thing that we want to talk about is referrals, and we mentioned this earlier, Joel, but the allied health visits, you get the extra EPC visits on top of your 715. Was there any comments? I know, Tremaine, you mentioned about the specialists and potentially bulk billing other specialists and allied health before. We probably covered most of this, but was there anything else that jumped out that you wanted to mention?
Yeah, I guess, we did, cover this a little bit earlier. I guess it's more information for, our nurses and GPs out there that these are additional to your GP management plan EPC visits. So yes, being Aboriginal, if you've had a management plan and a 715, you'll have access to 10 of these visits. Okay, they are different forms, so just make sure you've got that in your system or in your software. Okay, but yeah, like I said, I just explain it to them after the 715. These are the people you can go and see. And I do it several times a day, so I could rattle it off the top of my head, but I'm not going to. And how much you save and who we bulk bills, and always refer to them to people that we know that bulk bill, if possible. And for that too, like it could be, I know we're live streaming, so it's not just this Newcastle area. It could be just your practice going out and developing a relationship with a podiatrist or a physio or an exercise phys, and say, hey, if we refer to you, do you mind bulk billing our patients, or bulk billing Aboriginal clients and stuff like that. So build that relationship within your own communities, and it'll be a lot more beneficial.
Great. All right. Thank you, guys. Let's let you off the hook for now. Yeah. Just for now. If there's time, we'll come back and grab a couple more questions because there's some really good questions. But thank you very much for your insight into the 715 health assessments, and we'll see how we go for time. We're a little bit over, but if we've got time and I stop talking, we'll be able to do a little bit of a question answer at the end with those great questions. So now I'm just going to hand over to Tony Manton. So Tony is the Integrated Team Care Coordinator here at the PHN to talk about all things ITC.
Hello everybody, hope you're all doing well. My name is Tony Manton. I am the ITC Commissioning Coordinator at the PHN. Firstly, as always, I'd like to acknowledge the traditional owners on the land on which we're standing on today, and everyone's online, and pay my respects to elders past, present and emerging, and all my brothers and sisters in the room. Little bit about me. I'm a Kami-Pinga woman from Worimi Nation. There's a couple of photos that you might be able to see of my beautiful country, which is a little place called Kura, which is about 40 k's north of here. So I like taking my dog up there and relaxing, and there's me and my brother under the big beautiful tree up there. So what is integrated team care? Should you ask? Well, it's a coordinated care coordination supplementary services program. So it has three components to it. So our Aboriginal outreach work, and just heard from Tremaine about how effective an Aboriginal outreach worker can be, assisting people with attending appointments and providing that cultural support. Also talking around health literacy. The care coordinators are around coordinating the services as well as health literacy and supporting to achieve self-management of the patient. Supplementary services is a funded bucket of money for our service providers that can pay for things like medical aids, assist with any payment of specialist services, and can also pay for any transport if required. The main objective of this program, though, is to source any other funding opportunities before you actually pay for any services out of the supplementary services bucket of money. To be eligible for that program, you have to have a chronic disease, have a complex chronic disease, so not being able to manage a range of multidisciplinary appointments, that type of thing. As a guide, a patient's most likely to benefit from ICT activity who require more intensive care coordination than currently able to provide by general practices or AMS staff, who are unable to manage a mix of multidisciplinary services, who are at greater risk of experiencing otherwise avoidable hospital admissions, who are at risk of inappropriate use of services such as hospitals, emergency presentation. So those guys that can't really manage any of their appointments are the guys that really benefit from this service, who are not using community-based services appropriately at all, and who need to help to overcome barriers to access services. They might not have any family or any other people to be able to assist them. So if that sounds like a patient you have in your practice, then definitely ring one of our ITC providers, and I'll show you a list of those towards the end of this presentation. And get in touch with them and talk to any of our care coordinators or intake officers on the line at any of the services that I'll show you, and have a conversation with them about, does this person fit that service? One of the best ways to refer into the services, utilise our Health Pathways page here at the PHN. This is our New England, Hunter New England page. So you can type in your username and password, which appears on the screen here, And what you will actually do then is navigate down to, this is the Health Pathways landing page you'll come to. You'll then go to, sorry, a little bit, just go back. So if you have a look down the side of the page, you'll have a whole range of categories that you can click onto. And the one that you want to click onto is specific populations. From there, that will take you to Aboriginal and Torres Strait Islander health. And then what you want to do is click on to ITC Care Coordination Supplementary Services link. And you can access any of the referral pages, or referral forms, sorry, when you click on any of the regions that you want to do. And again, if you're joining us online from the Central Coast, you can go onto the Central Coast Health Pathways page and navigate again through specific populations and click onto those links, and it'll bring you to the referral organisation down on the Central Coast. So these are our ITC providers. So we have Yeren Aboriginal Medical Service down on the Central Coast. We have Hunter Primary Care, which cover the Newcastle Upper and Lower Hunter here in Newcastle. In Tamworth, we have Healthwise, and they cover the Tamworth, Northwestern and New England area. And in Taree, we have Biripi Aboriginal Corporation Medical Centre. Now, again, all their contact details will be on our Health Pathways page. So if you want to get on there and have a look, all the contacts, the eligibility, the referral forms are all on there. The next thing I want to talk to you about is a GP checklist that we've collaborated with the AHNMRC. Now, it's the first collaboration in New South Wales between the AHNMRC and New South Wales PHN, and we're really, really excited about it. So 7 PHNs from across New South Wales supplied data, and one of the things that it really highlighted in this collaboration was the proportion of Aboriginal people that are accessing mainstream general practices. There's anywhere between 57 to 97% of Aboriginal peoples that access mainstream general practice, with an average about 70.8% of the population, of the proportion of Aboriginal people that are accessing those services. So the checklist was adapting of an existing WA document, so to provide easy reference to the routine care of Aboriginal patients during COVID. And that's why we come up with the checklist for. It's been highly consulted by over 30 Aboriginal and non-Aboriginal clinicians in primary care. So it was really extensively collaborated with across huge amounts of people. Now, if you want to access this, it's actually currently not live on our page at the moment, but again, if you access our specific populations again on our Health Pathways page, and then go to some of these resources on there, you're going to find that on there. As I said, hopefully it'll be live. This is in draft form at the moment on that page, but it should be live by tomorrow. I'm happy to take questions. If you want to find out a little bit more about the ITC program, either give me a call at PHN, or again, if you want to call any of our ITC providers, they'd be more than happy to answer any of your questions. And that's the end of my presentation for tonight. So I'm going to ask Jess, who is one of our Aboriginal Health Access officers, to come up and talk through her part of the presentation. Thanks for listening, guys. I hope you enjoyed the night so far.
Yama, hello everybody. First of all, I'd like to acknowledge the traditional lands that we meet on tonight. and the traditional custodians of those lands and their continuing connection to country. So I'll just be briefly talking about the resources that the Primary Health Network can help you with regarding Aboriginal health. So we do have some on the screen here to show you just some examples. So I'm not sure if you can see those there. So the first one is the health guide to Aboriginal Torres Strait Islander patients flowing through your practice. So like that patient journey through your practice from identifying your patients right through to that follow-up care. So that's a great flow chart to utilise for that. The next one's the telehealth guide. So that one came out due to COVID. So we worked on that to give you a better support around conducting a 715 via telehealth. So that looks at before, during and after your telehealth appointment. So lots of good tips in there. The next one is more so for your patients. So lots of patient resources we've got as well. So we've got brochures like what is a 715. I think it's a bit of an assumption that all people know what a 715 is. So that's a great resource to give your patients as well, just to read a bit more about it. Even if they come to existing 715 appointments, it's great to hand that out as well, to give a bit more insight into that appointment. Also to utilise in practice for Aboriginal health would be the Community Health Pathways and Patient Info websites. They've got lots of useful resources on there. Also your clinical pathways regarding Aboriginal health, but everything is on there that you need, including links to those templates coming up soon, those new age group templates. You can also find them on the RACGP website if you're needing those. And if you'd like to contact us on how you integrate those into your software, we may be able to support you around that as well with our primary care improvement team. Another useful resource is the National Guide to a Preventative Health Assessment for Aboriginal and Torres Strait Islander patients. That is the guide to that 715, so sort of your reference book. So that can be found on the RACGP website as well. And it's also handy to keep that as a PDF on your desktop, just for a quick reference. We do have limited resources, a few hard copies as well. If you contact us, we can get those to you, and some useful pull-out charts for age groups as well. So the next slide, another resource that we have just developed is the Social and Wellbeing Community Services Directory. So more so your community services directory for your patients. So Health Pathways will address all your clinical referral pathways, but this is more your holistic community referral pathways. So for example, employment, education, emergency relief, housing, it's all in there. So for that holistic side, which is very important to address, the social emotional wellbeing, that directory will be very useful. So there's two directories coming out. One is for Hunter New England and one's for Central Coast. They will be made available on our website and Health Pathways coming up soon, but we will notify you via email when that's live on those sites. So yeah, if any of these resources will be handy to you, you can let us know as well, and we can come out and do some quality improvement exercises with you. That's always handy for your QI PIP. So if you want to do QI around Aboriginal health, yeah, we can most certainly help you with that, with our resources, some cultural awareness training, anything that you'd like to discuss regarding Aboriginal health, we can come out and support you guys as well. Okay, so over to you, Brendan. Mindful of time, so if you wanted to discuss what our team can help you with, or I think we've pretty much covered that, so I think this is just our contact details and a bit of a review on what we can support you with.
Yeah, a bit of a who's who in the zoo, and I mentioned earlier who we are, but there's some email addresses of our team, so feel free, depending on what region you're in, to drop us an email to provide some support around these areas, and you can see the list of types of things that we can support with as well. Joel's just been answering a couple of questions on Slido there, and we're going to have just 2 final questions just to ensure that we finish on time. But while we're just waiting for Joel to come up, we're just a reminder that the evaluations are really important to us here at the PHN, so we can continue to develop content that's relevant to you. So we appreciate your feedback. So if you go to polls on Slido, the code for Slido again is 715 if you've logged out of it, and complete that evaluation. So the final 2 questions, Tony's just picking 2, and we do appreciate all the questions.
Yeah, don't worry about Joel because Ryan can answer
There
this
we go.
question. Yeah, he is all over it. So Tremaine, can you explain the difference between an Aboriginal health worker and an Aboriginal health practitioner?
So I guess words are different. No, I'm joking. I'm joking. So Aboriginal health worker, generally you'll get that title when you do your Cert 3. So Cert 3 in Aboriginal and Torres Strait Islander primary healthcare. To become an Aboriginal health practitioner, you have to complete your Cert 4, which is like an additional 18 months, and then register through APRA. So you can, I guess it's more regulated then, you know, like I've obviously have to be more accountable. I've got, you know, the APRA registration. So it is a little bit more, what's the word I'm looking for? Not educated, but...
Yeah, you got more training.
More training, yeah, that's the words, I
So
guess.
what types?
More clinically trained
Yeah, so more
for that?
clinically trained,
Yep.
you learn everything. I mean, you've got to do 500 hours before you even pass it. You have to obviously go through the broadness of holistic health. So you cover every single aspect of everything we've talked about at the moment. But I guess the main difference is the only way to become a health practitioner is to do your Cert 4 and register through APRA. Then you'll actually get that title. You can do your Cert 4 and not become a health practitioner. It's completely personal preference and personal choice.
What types of things could a Aboriginal health practitioner do that a Aboriginal health worker can't do? Is it?
Well, I guess it's just that you obviously do further studies, you know, so you're a bit more inclined. Like I do pretty much everything that a nurse does, except we are trained in immunisations, but there's a law in New South Wales that says that Aboriginal health practitioners can't. But if I was to go to the Territory or I was to go to remote communities, I can. So that's very...
Oh, the New South Wales Poisons Act, I think.
Yeah, the New South Wales Poisons Act. So, you know, it's a bit frustrating that you have to go through and learn that to be nationally accredited, but then you can't use it unless you do go remote or Northern Territory where their laws change. Also, we can get a provider number, and hence you see that on the EPC referrals. So they can obviously generate MBS items or MBS money for the practice as well. Probably the main differences, I guess. Yeah.
Great. Tony, lucky last question before we finish up.
Oh, it's a doozy too. I'm just going to be about Joel. No. One of the requirements from Medicare is to document if any referrals or interventions are needed. What would you classify as an intervention?
Just educating is an intervention. So, you know, I always write discussed a treatment plan for, you know, just say lifestyle changes or, you know, and just specific things that we spoke to, like what Tremaine said, you know, just let's aim to cut down your cigarettes by 1 a week for weeks. That's an intervention to You can go as specific as you like, but they're all interventions, or your plans, or your goals or outcomes, whatever you want to call it. They are interventions. That's how I take it anyway. So it's. But and I find that a lot of the 715s don't have a plan or don't have 715 check health. There's always something to put in there. There's always, we can all do better with our own health. I can definitely do with some more exercise. And it's just a matter of documenting that, and it's not usually a problem, but it's for the patient. It's not. Medicare have their requirements, but you can always argue that this is what we discussed with the patient. It may not meet the Medicare requirement, but the patient was happy with this plan and this intervention as an intervention.
Yeah.
And no one's going to argue with that. So, but look, make it simple. It doesn't have to be we're gonna change the world and clean out the feral dogs and stuff like that. Nothing like that. But it's more simple things.
Yeah,
That's great.
I find that is just simple things, and it's achievable goals for them.
Exactly, achievable goals.
I'm not gonna, for my part, I'm not gonna tell them. Okay, now you eat 5 veggies, your 2 fruits. We need to cut all that coke out. We need to cut your cigarettes and pile a list upon them. It won't work. They will just leave and live their life as the way they are. But if you say, cut a can of coke a day or a cigarette a week, little tiny goals. Obviously, then you can use your follow-ups, your 10987s when they come back, and you can talk to them about it. It is more achievable for them, it's more realistic for them, and they're all interventions. Like I said, it can just be something as simple as that.
That's great. Thank you, everyone. And I'd just again like to thank the guys for their time tonight and all our speakers. I hope you all got a lot out of it. And, just keep in mind that, engaging with your Aboriginal community doesn't have to be onerous. It can be just as easy as asking some questions, sitting down, spending the time with your patients. And if you get a chance, familiarise yourselves with the latest Close the Gap targets that have just been released as well. And again, we really appreciate all the work that does happen out there within the region, in general practices and in the AMS sector for the Aboriginal community. And if there's any other questions, the contact details for the team are on the screen now. And again, please complete your evaluations on Slido, and we will thank you for your time tonight and joining us. Thank you.